glad to have Dr. Tamara Huff. Sorry, I was just clicking my got it message for the recording. Dr. Huff is an orthopedic surgeon and her practice in Columbus, Georgia. Vigio, I'm not sure how to pronounce it, orthopedics. I was catching a little bit before everybody came on about, sounds like she's doing some different things in different parts of the country. And so maybe she'll share a little bit about that with us, providing care at hospitals all over the place. She is committed to pursuing community outreach and education. She's an active member of the executive steering committee of Movement is Life, which she may talk about today, but that's how I first became familiar with her work, through involvement with that organization. And she's also involved with the Columbus chapter of Links Incorporated and the Columbus alumni chapter of Delta Sigma Theta Sorority. And so we're very excited to hear her talk with us today about musculoskeletal health disparities in the time of COVID.
Thank you so much, Kelly, and good morning to everyone. It is kind of refreshing to get here and everything. I've missed seeing your smiling faces, but I'll make do. Let me share my screen so we can get started. Okay, guys and gals, can you guys see me okay? Take that.
That's great.
Okay, terrific. All right, let's get started. So please feel free to drop a comment in the chat. One of my lovely Delta Sigma Theta sorors said hello already, so I'm excited about that. So please feel free to drop a comment in our chat, and I'll try to address the questions as we go along. I do have some kind of interactive things that I would love to, again, have you guys drop something in the chat. Research, as you guys know, shows that our adult attention span is about 25 minutes before we need a dopamine hit. So I'm going to try to keep this lively, but please, again, feel free to drop messages in there and I'll try to answer those. Also, too, at the end, if there's something I didn't cover, please feel free to drop a message in or ask a question, because that's what this is about. So let's get started. Addressing musculoskeletal health disparities in the time of COVID. And again, I thank you so much for the invitation from Dr. Callahan. It's just been amazing, the things that we've had a chance to do together at the Osteoarthritis Action Alliance. So really excited to be here. Let's see. Okay, so just a little bit about me. Let me introduce myself as well. Again, my name is Dr. Tamara Huff. I'm a board certified orthopedic surgeon with a special interest in adult reconstruction and fracture prevention and treatment. In 2019, I founded Vigio Orthopedics, where our mission is to really increase access to musculoskeletal care in the US. And it's a three-pronged approach. It's the approach of actually providing care in underserved areas. So we were chatting about a little bit before we got started about where I practice at. I've practiced in Georgia. Currently, I'm practicing in Baton Rouge, Louisiana. I've practiced in Kansas. I've practiced a variety of different places because those are the places where there's a need. Also, too, the second prong of that approach is bringing community-based interventions into these communities. So really looking at how do we partner with private organizations, with healthcare providers, to really bring the information in a format that people can understand. And the third prong of Vigio is to increase the number of musculoskeletal health providers by supporting people in the pipeline. So that's just a little bit about me and what I'm doing. Also, too, as Kelly said, I'm a member of the steering committee of Movement is Life. And Movement is Life is a collective of surgeons, primary care physicians, nurses, physical therapists, the faith community, pharmaceutical company people, people from the insurance companies, basically all the different stakeholders that you could think of in the musculoskeletal space. They're coming together to decrease health disparities for women of color and women in rural America. So I've been a part of that group for almost 10 years now, and just has been a phenomenal opportunity. So we'll talk a little bit about that, but if you guys have any questions about that work, I can definitely share it. And please don't get too mad at me that I am getting my executive MBA. I'm graduating in May, yay, from that school down the street. So please do not hold that against me, okay? One of my focuses in my MBA training is health sector management and health policy. So We do have a little bit towards the end about healthcare policy. And if you all have any questions or want to kind of dive in a little bit deeper about that, again, please feel free to ask a question about that. Okay, enough about me. Let's get started. So really today's topics are threefold. We will talk about what are health disparities, especially musculoskeletal health disparities, who's being affected, like what they are, what kind of things are happening with those, and the impact of COVID in respect to that. So what kind of, was there anything good that we could have out of COVID, and the bad, and of course the ugly about it. And then lastly, I think most importantly, is where do we go from here? How do we come up with novel, comprehensive solutions to this problem? And really, we do need to look at it from multiple different perspectives. So I offer a three-pronged approach to how to address this in the future. So just from a broad scope and to level set, arthritis in America is a problem. 1 in 4 American adults, over 54 million people have arthritis. 67 million people will suffer from arthritis pain in 2030. What's interesting about this, and I didn't add in the additional slides, but if you overlay obesity onto the same map, it's more or less the same. I'm originally from Georgia, born and bred in the South, and practiced most of my life in the South, and we see this every day. We are suffering, and disproportionately so. Now, something that's very near and dear to my heart is arthritis in rural America, and I think people really underestimate how many people are affected. The highest prevalence of arthritis is in Appalachia, but also it's extremely high over in the top 25% in other counties in other states. So Alabama, Arkansas, Kentucky, Michigan, Missouri, Tennessee, and West Virginia are all in the top areas. I've had a chance to practice, well, I had a chance to work with people in many of those states, and it's a challenge. It really is a challenge because when you are suffering from arthritis, it affects every aspect of your life. And again, when you have up to a third, if not more than a third of rural residents facing this, this is a major challenge. So are we really serving people as we should? So in rural America, we have this disproportionate number of people with arthritis. But many times, again, we think arthritis, or we think healthcare in general, is more of an urban issue. Over 50% of American hospitals are actually in rural areas. I think for me, that was kind of mind-blowing, especially before I started practicing out there. And out of all these hospitals that are there, less than a third of those hospitals actually have a full-time orthopedic surgeon. And over 65% never have a surgeon on call. So if we think about, this is the part of the country that has some of the highest rates of arthritis and joint pain. Over a third of the population is suffering, and there's no orthopedic surgeons there. There's no one that can get that care. So as we go along, or excuse me, that can give that care. As we go along, we'll circle back around to how the social determinants of health play into this. But I want you all to think about that. How does that work? You know, how do these people seek care? Many of our rural areas don't have the infrastructure that the urban areas do for transportation. So many times when we have and think of the face of health disparities, we think of urban people in urban environments, low income, but there's a serious issue out there in rural America. Oh, and also I put most of the references on the slide. However, in my notes, I do have references if you all need any of those, and I can share them later. So when we again talk about health disparities and things of that nature, we're kind of going from the bigger problem in the US and kind of coning down to smaller and smaller groups. So arthritis is a major issue for women. The disease burden of arthritis is 56% higher for women versus men. Women have a higher chance of becoming disabled because of that. And this disparity continues at all ages. Some of the work that I did with the American Academy of Orthopedic Surgeons, Women Health Advisory Board, looked at gender and sex differences in arthritis. Involves all different parts of the body. We see it in hands, we see it in the spine, we see it in shoulder injuries. So there's a lot of disparities there between the two sexes. So that's, again, something to keep in mind when we're thinking of what's the face of health disparities for us. Arthritis in particular in people of color is a main concern. So we've already talked about arthritis being prevalent in the US, but especially in racial and ethnic minorities. Typically, these groups get arthritis at a younger age. So in the US, over 2 million people under the age of 45 actually have knee arthritis, for example. Knee arthritis can be quite debilitating. And as surgeons, we oftentimes don't want to operate on people that young because of the risk of having to have a revision surgery or an additional procedure down the line. So what do these people do? Again, over 3 million racial and ethnic minorities have symptomatic knee arthritis. And there is an argument, and our data supports that many of these people have pain and dysfunction much higher than the general population. So how are we going to address these younger patients that have a higher level of lack of function and disability? And of course, arthritis, the double whammy of unfortunately being a woman and a woman of color, that intersectionality causes even more issues. So over 54% of African American women have doctor diagnosed arthritis in the last 5 years. And I put doctor diagnosed because if you think about it, and we'll talk about the issues of access and getting offered care, I argue that number is much higher than that. Again, this comparison to only 37% of our Caucasian cohorts. And again, these women are suffering with a disproportionately high number, have pain and disability from arthritis. So again, what kind of quality of life are the general population and our patients receiving? So as we move forward, many times I use the term health disparities and healthcare disparities in an interchangeable fashion. However, they are a little different, and I do like to highlight those differences. So health disparities is basically a higher burden of illness, injury, disability, mortality experienced by one population group relative to the other. So the things that we just went over kind of as background information, those are health disparities. That can also play into healthcare disparities, which is the difference between groups in healthcare coverage, access to care, and quality of care, which again are very important and interconnected issues. So we've briefly gone over kind of where we were set, what was going on before the COVID crisis. Let's move into now, how did the pandemic change all this or augment all these different things? So I think a lot of times when we talk the discussion and the discourse around social determinants of health disparities, it was always there. We've been doing this work for 10, 15, 20 years. It's always been there, but it really hasn't come to the forefront until these last few years. So I always like to talk about before COVID came, African Americans were more likely to die at early ages from all causes. So, I mean, significant disparity. So if you're looking at this particular infographic, the maroon color are African Americans, and the kind of I guess it's turquoise color there is the general population. So we have to be careful because many times when we focus on COVID disparities, we think of, oh, this just happened. No, this has been an issue for a long time. And it's not deaths necessarily from violence or things like that. It's death from heart disease and things that we could prevent, we can treat and prevent. Again, this slide is important because it's talking about high blood pressure, diabetes, stroke. Those are all comorbidities that we think about with our surgical patients. So many people ask why I spend so much time and I talk so much about non-surgical things. So things that have nothing to do with, well, you would think initially have nothing to do with orthopedic surgery. Well, we need our patients to be optimized. And if your blood pressure is out of control, if your diabetes is out of control, then it puts you at a higher risk of complications. I do not want you to have a perioperative stroke. We need to be mindful of all those things because it affects the quality of a candidate and your outcomes before surgery, and of course your outcomes after surgery, and the quality and the improvement that you get with surgery. So we want to do the right thing for the right person at the right time. But again, this slide in particular demonstrates, again, these persistent disparities between African Americans and Caucasians at all age groups. And this is not just something that we see in African Americans and Caucasians. We also see a Hispanic population. Poorly controlled high blood pressure is a huge issue. Also, I would argue diabetes is. So again, you can see how before we even get to COVID, this population is a setup to have disproportionately high effects and infections and deaths from COVID. So we won't spend a ton of time talking about deaths from COVID in this population, because we know, I would argue that all of us know those statistics. If not, I can share those. But these groups already were primed with the comorbidities that put you at a higher risk for more severe symptoms from COVID-19. So why are we surprised that their outcomes are worse? What I like to transition to now is to talk a little bit about the social determinants of health and how those all play into it. So I like this little graphic because it talks about the 5 basic things or pillars of the social determinants of health: education, access, quality, healthcare and quality, neighborhood, environment, social and community context, and economic stability. But when we talk about the social determinants of health, really all the things in this list are things that relate to patients' overall healthcare prior to the pandemic, and can be an underlying cause of disparities before the pandemic. And you can easily see how each one could have expanded afterwards. Feel free to chime in if you want to share an example, or I'm just going to briefly kind of go through these and how each one was affected and kind of affects our musculoskeletal patients as well. So overarching issue is the fact that many people there's a disproportionate number of people of color and women who are in this healthcare sector, as well as the emergency workers that aren't able to take that time off. So they're more exposed to COVID to start with. Many of those jobs that these particular groups that we're so concerned about don't have sick leave or income protection and things like that. Now, our government, we can talk about the pros and cons of some of the aid the government has offered in the interim, but there wasn't that social protection. Educational opportunities, schools have been shut down. That is a major issue on multiple folds, but one, education from just having the knowledge to understand the information that's coming out about the pandemic, but also knowledge to have the education to understand how can I better my knee, how can I take care of myself until I can get back to the doctor. We mentioned job security, working conditions. I know that there is a significant agricultural community in North Carolina, same thing in Georgia and Louisiana, ensuring that population had access to care, that had PPE, that when there were injuries with everything going on, that we could still get them into the hospital. That was an issue. That was a concern during the height of the pandemic. And again, if we want to talk a little bit more about those specific things, I was still operating and working the whole time through it, so I can kind of share that perspective from a rural health perspective as well. Housing, basic amenities and environment. We also know, again, that many people of color, many folks in these underrepresented groups have living structures that are different. They're multi-generational households. That facilitates the spread of COVID, but that also makes some unique challenges when we talk about consenting people. Well, what do we do with patients after surgery? Where can they go after surgery? What are their options and things? Early childhood development, we talked about that a little bit, about school, as well as social inclusion and non-discrimination. That's a whole, the idea of the construct and the role that racism plays in all this is actually a whole topic in and of itself. So we can dive into that a little bit more. And this idea of structural racism and that social construct. I don't dive into it in my slides, but if we would like to have that dialogue, I'm more than willing to open it up at the end. And then access to affordable health services and just of a decent quality. Now, one of the, I would argue, one of the few good benefits of COVID is the fact that the expansion of Medicaid actually happened, whether you wanted it or not. So you all may be familiar with Medicaid. Normally with Medicaid, there's very strict criteria on whether or not you can come on, and then you're basically pushed off as soon as you lose eligibility. So it's not this prolonged period that you're on Medicaid. Well, part of the pandemic program that came from the White House was allowing people to stay on Medicaid during the pandemic. So this has created a windfall of access for a significant amount of the population. Now we'll get to one of the later slides, and one of the things we have to think about consequences and things moving forward is, so the pandemic prayerfully will not last forever. What do we do with those patients, with those individuals that no longer qualify for Medicaid in their state? Like, what happens? Do they become uninsured? Do they find insurance on the healthcare exchange? Like, what happens to those patients? So one of the very small silver linings of this particular pandemic, that and telehealth is another good silver lining, is the fact that a whole group of patients, millions of people gained access to care through Medicaid. What's going to happen with that? Everybody hanging in okay? All right, we're going to continue on. So this is really interesting because I think there's a lot of unintended things that happened in COVID with musculoskeletal care that were emphasized, but not really, because again, people don't really think of orthopedic surgeons as frontline healthcare workers. So one of the biggest things in the news you may have heard of, or that definitely affected surgeons, were canceling elective surgeries. Now, traditionally, when you think of elective surgeries, many people think of plastic surgery and things like that, but total joint replacements are elective. Some fracture care can be deemed as elective. So that can be a challenge for patient quality of care, because as we all know, osteoarthritis can be absolutely debilitating. Pushing off your joint replacement for 6 months or a year, it affects your quality of life. It affects your ability to generate income. It affects many different things. In addition, it really challenged private practices to continue on, because that's the main source of income. It challenged hospitals, who of course are given all this COVID care, but the main income stream for the hospitals has now been cut with the cutting back of surgical services. So this led to staff layoffs and redeployment into other departments. So while elective surgeries are now back, that strain is still there. That the staff that was lost during that time, the financial detriment of that period where no surgeries were being done. Also, from a patient care standpoint, a lot of patients were sent out for things that we may have operated on. So what we saw as the pandemic restrictions lifted is people coming back in with malreduced fractures or issues of things that could have been cared for differently, but there was fear of going into the hospital. And what do I do? There weren't resources. There was no one available. So there's a lot of challenges and unintended consequences there to patients as well. When we really had no other choice but to cancel those elective surgeries. The second part is limited resources, and the resources have been limited for everyone. But I would argue this is much more concerning for rural areas that are already underserved. So as we talked about in the earlier staff, these hospitals started off with limited resources from the beginning, and that staff got even more limited during that time. There were significant supply chain issues. Yes, we still have those supply chain issues, but at the height of the pandemic, there was a rule invoked by the government saying that you had basically diverting, and I apologize, I'm blanking, but basically diverting supplies from other industries to making masks or to making PPE. And so part of those controls were that you could only order but so many things that you've already had. So for example, a small rural hospital could, the max amount of gloves, for instance, they could order where this was the same amount that they were ordering 3 months prior. So in a small hospital where you're only serving 15,000 people, maybe you only ordered 100 boxes of gloves. But now you're seeing this influx and you need 300. Where did those gloves come from? Where did those supplies come from? So those type of supply chain issues we saw all through smaller hospitals in the rural areas. Yes, if they had stockpiled, great, but in many cases they couldn't get what they needed because they didn't have that buying power from the beginning, that they were only had a small amount of supplies that they usually ordered. So things were being rationed more than people really realized. Also along that same line, and something that, again, people you don't think about unless you're in those smaller areas, is implants, surgical implants. So I worked in the state of Kansas, and at one point during the pandemic, there was only one set of this particular company's implants, total knee implants, in the entire state of Kansas. And when they ran out of that one little liner that we needed, that one piece of plastic we needed in that knee, the closest next supplier was in Nebraska. So we have to think about, yes, our supply chain was actually pretty thin beforehand, but it's even worse now. So when we think about supply chain, it's not just the PPEs, it's also implants and medical devices. It's where the upstream things, the original natural resources came from in the beginning. So there's many, many levels to the supply chain. It's not just the one distributor that you're getting it from. And unfortunately, with what's going on in Ukraine and in Russia, we're probably going to see some interesting supply chain challenges in the medical industry moving forward. Also, too, when we talk about limited resources, something that you, again, may not think of is the blood supply. So there's constantly a blood shortage in America. If you donate blood, you probably get plenty of those emails from, like I do, from the American Red Cross of it's time to give blood again. But again, in rural areas, this is magnified because of the distances between people. So if you already have less people donating blood because of COVID, now that surgery or that even that emergency surgery you were going to have, if you type in screen and find out they have antibodies, you may not be able to do that emergent surgery for days until you're able to secure the blood that that patient needs. So again, these are things that are nuances that we don't talk about a lot that have real world consequences. And again, they were already issues, but with COVID just really magnified them, especially in the rural landscape. And lastly, COVID and the pandemic, of course, and the things that set up really expedited the transition to outpatient surgery. Now, that can be a very positive thing because getting patients home faster is shown, depending on the procedure, better outcomes, higher patient satisfaction. It limits the burden on the healthcare system. So that is an inherently good thing, but there are, again, some unintended consequences that we'll go into about this transition to outpatient surgeries. So a broad way of looking at this transition again to outpatient surgeries is and the consequences of that is cherry picking and lemon dropping. And basically, as surgeons, we try to mitigate all the risks we can for our patients. We want the best possible outcome for our procedures. And really, that starts with patient selection. So even before the pandemic, with bundle payments, which we'll get into a little bit later, surgeons were already looking at optimizing patients, or basically looking at how do we pick patients that are in the best shape possible, that we can do the best procedure possible, that we can get the best outcomes possible, because our reimbursements in this time of value-based medicine is tied to outcomes. So we want excellent outcomes, and the easiest way to get excellent outcomes is pick excellent surgical candidates. So our healthy individuals with normal BMI, they have minimal health comorbidities. If they have hypertension, they're on one medication for it. If they have diabetes, it's diet controlled. They have excellent family support, so they can go straight home after the procedure. Those are the cherries. Those are the patients that everyone wants. Those are the people that have private insurance. That's the gold standard patient you want. Now, high-risk individuals, we were already having problems with them not being picked, because patients that have morbid obesity, and we're actually finding out that's not as big of a risk factor as we thought initially. Uncontrolled diabetes, malnutrition, they're smokers, they have poor family support. So what do you do for discharge planning? These patients overall are high-risk patients. So even before the pandemic, those are the folks who are like, whew, we got a plan for these. They're going to cost more. They're going to be in the hospital longer. The potential of them having a DVT is higher. It's going to take more resources, both mentally, physically, and financially, to take care of these patients. So there was already a little bit of cherry picking and lemon dropping happening. Now, we put on top of that the pandemic. So the transition in orthopedic care has already been going to outpatient procedures, but now we really have to speed that up, because we can't take anybody inpatient. Well, our healthy individuals have no problems. We can continue to do their joint replacement. We can continue to do their elective surgeries because they're coming home. But we really have to stop and think about how many of these high-risk individuals can we do now, because these are the people that really do need to be in the hospital. They may not be able to go to ambulatory surgical center. They're the ones that are going to need that extra day. They may need a SNF. They may need a SNF, skilled nursing facility, or a nursing home. They're going to need placement. What do we do with those patients? So let's finish up with talking a bit about solutions. And really, we're going to look at this from a three-pronged approach for patients, providers, and payers. Again, if you have questions, please feel free to put them in the chat, and also at the end, we can take some additional questions, but here we go. And hopefully everybody's out there. If you need to stretch, especially if you have your camera off, feel free. So from patients' perspective, what can our patients do and in their communities do to really get health disparities under control? I am a huge believer in the benefit of community-based interventions. Through Movement is Life, which I discussed with you before, we do a program called Operation Change. I personally was a program director for one of the programs, and I've worked closely with it ever since in other areas. But basically, it's an 18-week program. It's based on increasing movement in African American and also Latino women. And we actually have a rural woman cohort in Hazard, Kentucky. That's pretty amazing. But all these different groups, these women get together in their groups, and the focus is on behavior change and education. So we're giving community-based leaders are coming in, talking to them in an interactive manner. They're getting physical activity, and they're actually getting motivational interviewing skills to make the necessary changes to improve their overall health. It is not a weight loss program, but it's a comprehensive program to build stronger relationships and increase the individual's overall mental and physical well-being. So one of the pictures up in the upper right-hand corner is our cohort from Chicago. We've had the opportunity to do the program in Los Angeles, Chicago, Hazard, Kentucky. I did one in Waycross, Georgia, down in Louisiana. I think, I'm trying to remember where they were in Louisiana. Our Lady of the Lake, I think, as well. We've also been up in New York. So, and I believe we have a program starting in Pennsylvania very soon. So it's a terrific opportunity. Again, I can talk about that more later. Of course, Walk with Ease, which most of you all are probably familiar with. with the Osteoarthritis Action Alliance and the Arthritis Foundation. It is a terrific program. I've definitely referred patients there and been involved with that. And especially now that there's an online component, it's really a nice setup. Girl Trek. This is a program that is started by two African-American women. That their goal was to get 1 million Black women walking around the world. And they have done it and surpassed that. And they just really focus on consistent walking most days and really help try to build community groups to walk in different areas throughout the country. So it's really kind of yes, it's exercise, but it's also emotional and spiritual support. Walk with a Doc, which is a great program that many physicians I've talked to work with. And it's a great way to get providers involved in the care. And of course, any of these ideas that you have, you gotta partner with a trusted community group and to make sure that that dialogue is there. So I am a huge fan of getting out in the community and helping people get more invested in their health. Also too, making sure that and doing outreach to make sure that patients are actually enrolled. Many people don't realize that healthcare, that you can still access the ACA plans on healthcare.gov. We'll talk a lot, we can talk now and also later about Medicare Advantage. It definitely has its pros and cons, but one of the things that the Medicare Advantage and a lot of these value-based models are focused on is preventive care. So patients can get the support for programs in gyms and things like that, that you may not have been able to get otherwise. And then also to making sure if they're eligible for it, Medicaid. And we can talk about advocating for expansion versus hanging tight where you are. Okay, from a provider perspective, there's a lot of things we can do to help with patient optimization. The American Academy of Orthopedic Surgeons has been very focused on this, as well as the American Association of Hip and Knee Surgeons, also known as AAHS. Together with Movement is Life, we have published a series. It's going to, in total, it'll be 12 articles. I believe we're on the 8th article now, on how to optimize patients for surgery, specifically for hip and knee surgery. This most recent article, our article just came out in January, I believe. And this is one that I co-authored with Mary O'Connor and Jenna Bernstein at Yale, looking at optimizing nutrition. But we also have modules and articles that are evidence-based on nutrition, on smoking cessation, on diabetes, on anemia, on renal disease. So amongst other, I know I'm probably forgetting some of them, but all of that is an evidence-based way that we can actually improve and get better outcomes for these patients. Also to educating providers from all perspectives on these unintended consequences of bundled payments. So yes, we want to have excellent outcomes with patients that have been optimized, but we do have to take that time to optimize those patients and be careful that we're not leaving people behind by not taking the additional effort of optimizing. One of the things we argue, Dr. Dan Wisnia, who's still at Yale, was director of this series of articles for Movement is Life and the American Academy of Orthopedic Surgeons. He really advocates, and I agree with it, having a comprehensive team-based approach for your patients. So working with a perioperative clinic, working with anesthesia, working with a trusted primary care provider to really have a team-based approach to these things. And that leads nicely to our last topic of policy and payers, because all of this is really a team-based sport, and it's really important to do an ounce of prevention versus a pound of cure, but you have to have money to do that, and you have to have resources. So the trends in healthcare policy is definitely going to a value-based payment model. So these are models that are on a spectrum of capitation, meaning on one end is fee for service. That means you go to your doctor, you pay out your money, and you get a service, all the way over to full capitation, which means that the health company or the provider gets a certain amount of money per person per month to take care of all these medical issues that that patient has. So definitely CMS is starting to swing more towards that capitated model, more towards that value-based model. It has some different opportunities there. One is with Medicare Advantage. Medicare Advantage is closer to that capitated model, but it's still ran by private insurance companies. So one of the unique things about Medicare Advantage and how it can help disparities is that you can do more preventive work. So in Medicare Advantage, there is the flexibility to pay for healthier meals, to get gym memberships, to look to get different food delivery services. There's a lot of options that aren't there in traditional Medicare. Now it has some of its other challenges, but that gives us an opportunity that maybe if our patients are in these value-based plans, perhaps we can have healthier patients that are ready for surgery, that really eliminate those disparities before we even get there. Also in the value-based payment model is the comprehensive care for joint replacement, CJR. This is the bundle payment model for joint replacements. It's constantly evolving. This has actually been shown so far to lower costs and increase outcomes. But again, all of these value-based models, you're incentivized for meeting certain metrics, but does that have a subconscious or even conscious disincentive to take riskier patients? So how are we doing those risk adjustments? This, again, I just left DC 2 weeks ago, actually a week and a half ago. I just left DC meeting with health policy people from the legislature to CMS to the CMS Medicare, Medicaid Innovation Center, looking at what they're doing. And they know it's a problem and they're trying to address it, but it's not there. And then I think a huge issue is then what is value? And I think that's going to help. That's really important if we're trying to address health disparities, is how do we determine what care is valuable? What makes something better? Is it just a patient being healthier, or is it a cost savings? What is value? And that is just really key in determining, again, risk adjustment on these different fronts. Also down here is Medicaid. And Medicaid is definitely transitioning to more value-based payment models that they're trying to mimic Medicare Advantage, but that Medicaid population is a different beast. It's a different population. And as we look for solutions, we have to be mindful about it. Medicare being patients over 65, Medicaid being women, children, disabled individuals. Right now, there's a lot of people that are just that meet the income cutoffs, but will that change? Medicare expansion, Medicaid expansion, what states are doing it? What's the pros, what's the cons of doing that? Medicaid is a much more state-specific program than Medicare is, which is national. And then we're coming up on the end of pandemic coverage. So what are we going to do with these millions of Americans that have been on Medicaid rolls? They're about to get kicked off. And then lastly, and importantly from a provider standpoint, is payment. Like, how are we going to continue to incentivize providers to provide care for patients that have Medicaid when the reimbursements many times are less than cost? So how do we continue to handle those financial constraints and still incentivize providers to provide that higher level of care? These are all challenges from, again, a primary care perspective, but it's actually an even larger problem when we start getting into specialty care. So in closing, that's it. I open it up for questions. I would love for you guys to stay in touch. If you have questions or if you just want to know what we're doing, again, Visio Orthopedics is at visioortho.com. I'm on Twitter and Instagram as Lady Bone Doc, and I'm on LinkedIn as well. So thank you guys so much for your attention and your time. And I'm going to stop screen sharing and open up for questions.
Thanks, Tamara. That was great. Really a wonderful overview from your clinical, administrative, and other perspectives. I don't know if you're going to see the chat, but Lee had a question in the Medicare Advantage in where you can pay for gym memberships, et cetera. Does it require a physician prescribing the food or gym membership to the person? How does that work?
That's a great question, Lee. So it kind of depends on the structure of the program. So with Medicare Advantage, there's about 37 different providers in the country that provide Medicare Advantage programs. And out of those, there's about 1,000 different plans between the different states. So it's really specific to the particular plans. Many of them are doing kind of like a healthcare navigator model where you have, you don't necessarily need to go to your physician to get that. You can actually go to like a wellness person or navigator, but it really depends on what that particular plan is set up as.
Okay, so that's more state by state. I don't know if Kirsten or Serena can jump in. I think some states, like maybe up in New York or whatever, have done this with Walk with Ease, where people can get things, but I guess you have to go. There's not sort of one central policy place that handles all of this.
No, but one way, so I guess if you're thinking about like, so how do we get our programs? Because that's something that I'm very interested in, is if we have proven solutions, how do we get those models to those different organizations? So great question. It's actually something I'm dealing with too right now. So I think one of the best options is to reach out to the plans. That would definitely be a way, and especially the plans in your area, because I was actually just looking up, you have 37 different plans, not 37, excuse me, you have 104 different plans in North Carolina. So if you go, I think it's MedicareAdvantage.com, if I remember correctly, you can actually type in your zip code and it populates what plans are in your area. So one potential way of kind of starting out is to reach out to those particular plans in your area and say, hey, we got a solution. Who do we talk to about that? So that's one option too.
Other questions? I have one. I'll jump in if I don't see any hands at the moment. So Tamara, you talked a little bit early on about, particularly, I think it was when you're talking about rural individuals and how they are often getting arthritis earlier, and what do you do? So I'm curious, what do you do? Like, so when you're, and it maybe it's, and not, and obviously it's not just people who are living in rural areas, but it's other racial ethnic minorities, it's veterans, people who get OA earlier and are in their 40s and have significant pain, functional limitations, and those sorts of things. What do you feel like is the best thing you can do clinically, or just maybe from a broader policy kind of perspective? That's really tough, right? Because you don't, as some of them may choose to have joint replacement surgery early, that's probably not the best decision for everyone. But it seems like without a whole lot of like ongoing monitoring and attention, they're going to get worse and potentially be in a worse place for surgery 10 years later. But I mean, do you see places what do you think the healthcare system could do best to serve patients who are in that situation?
That's an excellent question and concern. And that's something, I'm pretty passionate about. So this will be, some of it will be my own anecdotal experience, but also
That's
too,
great.
there's some nice studies looking at from ACUS on that, and American Association of Hip and Knee Surgeons. But study after study shows that physical therapy, exhausting all non-operative options before moving into surgery is key. So even if that patient, so I am, in my personal approach to this, I talk with my patients and say, hey, you're young. Ideally, we do not want to do your knee replacement this early because, you're going to have a higher level of pain. The likelihood that you're going to need to have a joint replacement again in 15, 20 years is extremely high. Once we have that kind of level setting conversation, most patients are like, okay, so what can we do? And I think that's the most important part, because I think as surgeons, many times we don't take that next step and say, okay, what can you do? So I do put them on. So I actually give them a home exercise program. And if they're able to and have the resources to, I am a fan of physical therapy. Aqua aerobics I'm a huge fan of that, especially if they have joint issues. Giving anti-inflammatories, you can talk about steroid injections and things like that, but all those different, that non-operative pathway. What is arguably even more important than all those things is regular follow-up. So we still check in on them every 3 months, even if it's just a quick pop in to see where you are, because if you don't do that, those are the people that sometimes get lost, that sometimes fall into depression, that sometimes are getting worse and fall into opioid addiction and things like that, because they're like, nobody's listening, it's not getting better, what do we do? Because sometimes you do need to pull that trigger, and they still can have excellent outcomes. But I do believe that it's very important that you at least give them a chance to see if the non-operative things work, and then have that follow-up, have that continuity is really key. I think for young people, for rural folks, for just pretty much people in general.
Yeah, thanks. That's really helpful. I appreciate your perspectives on that sort of regular follow-up, because it seems like for patients in those sort of situations, it's easy for them to get kind of lost and discouraged without those regular check-ins.
And Kelly, I'm sorry, I don't want to cut you off, but it just made me reminded me of one other thing. So one of the positive things that happened from the pandemic was the increased use of telehealth. And that is just really continuing to advocate for payment for those. Right now, there's 276 codes that are covered for telehealth right now and by Medicare, but continuing to make sure that we use that resource, because sometimes it is as simple, especially in rural areas where you can't travel or it's challenging to travel. A call can mean a lot, a video conference can mean a lot. So there are other ways that we can still have those touch points that can that are more amenable to transportation and other issues.
Yeah, that's great. Thanks for that comment. We have still about 5 minutes. Are there other questions?
I was just going to note that Katie put the link of how you can put in your zip code in the chat box.
Great. Thank you.
I'll just ask one follow-up, Tamara, about you just were mentioning increased use of telehealth visits, and in particular, since you work with rural patients a lot, have you seen their comfort levels with that increase over the past couple of years? Or do you see a lot of barriers in terms of just access for rural patients?
Again, a great question. So I'll start by saying part of the problem is broadband access and having good, reliable internet access. That's why I threw in the actual calls. I never cease to be amazed at how many of my patients have smartphones. And you would say it is an issue of them having like the device access for some people, but again, most patients actually have the phones. It's that access to the high-speed internet is definitely an issue. Being flexible, using non-traditional things. So again, doing the calls and kind of helping them be a little bit more comfortable. Also I think there's something to be said with that initial establishing care with a face-to-face visit and then moving into telehealth is also another way to kind of ensure that they have comfort levels. But yeah, over the last 2 years, I think telehealth is definitely not the answer to everything, but it's definitely something that should be in our toolbox.
Thank you. There's just some comments in the chat. Thanks for those. Okay, any final questions as we wrap up here? Tim, we really appreciate it. I think I've learned a lot. It was just such a nice overview of where things are, and you've got a great perspective on this. So we really appreciate it.
Well, thank you so much. I really enjoyed it. So yeah, look forward to seeing you guys and working with y'all again. Take care, everybody.